Hello. Hello. Can you guys hear me properly? Hello. Okay, that's great. So today we are going to continue our session on Bones tumor. As you guys remember that last time we were discussing Bones tumor, right? So let me just give you a brief overview of the previous session. Then we are going to continue our session further. Okay. Okay. So we discussed that bone tumors can be benign or they can be malignant, right? We discussed that in the end of every benign tumor, we are going to be having a word OMA in the end. While in the end of every malignant tumor, we'll be having sarcoma in the end. Okay. So the first tumor which we discussed was osteoma. You guys remember that? We discussed it's osteoma. So it's going to be a benign tumor. Mostly it's going to arise on the face associated with Gardner syndrome, which we're going to discuss in detail in our GI section. Then we discussed osteoid osteoma and osteoblastoma together. There were some difference between osteoid osteoma and osteoblastoma because we discussed that osteoid is being made by your osteoblast, right? So if we get a tumor or a cancer, a benign cancer, that's osteoid osteoma. So we'll be having a radiolucent core surrounded by a reactive bone, right? We discussed that the pain of osteoid osteoma can be resolved with aspirin. We discussed it's going to be less than 2 centimeter. Two, that was centimeter or millimeter? Yes, that was 2 centimeter, right? While in case of osteoblastoma, the pain won't resolve with aspirin and is going to be greater than 2 centimeter, right? We discussed osteosarcoma as well. It's a sarcoma, malignant tumor, which is going to be, mostly arising at the level of, we discussed knee joint associated with Paget disease, which we discussed in detail. It's going to have a Codman triangle sunburst appearance, which we discussed in our previous session, right? Okay. So today we'll be discussing giant cell tumor. Okay. So what is giant cell tumor? Okay. So we discussed that our bone have, different areas, right? We discussed we have this area is called as epiphysis. The area with the growth plate is called as, yes, anyone?
Metaphysis.
Metaphysis. And this shaft of the bone is basically called as diaphysis. So the
Diaphysis.
only tumor which arises in the epiphysis is going to be your giant cell tumor. Okay. Okay. So can we just wait for 2 to 3 minutes? It's Azan here. Okay. Hello. We're going to continue our session after Azan.
Sure, doctor, no problem.
Hello? Can you guys hear me? Okay, that's great. So we were discussing about giant cell tumor, right? So we discussed it's going to be mostly present at the epiphysis, which is going to be above the metaphysis, right? It's the only tumor which is going to be found here, right? Giant cell tumor is associated with some multinucleated giant cells. Do you guys remember what are your multinucleated giant cells?
Yes.
Yes, we were seeing them in, the same kind of features were seen in giant cells,
Granuloma.
giant cells, in granulomas, right? We discussed. So similarly, here you are also going to be having that kind of giant cells, right? Okay, and the region where this tumor is most likely to be present is at the knee joint, right? At the knee joint. That is your distal femur or proximal tibia, right? Distal femur and proximal tibia have your knee joint there, okay? And another characteristic feature, as we are having these giant cells, so they would appear as soap bubbles, right? They would appear as soap bubbles whenever you are just doing an X-ray, right? So in X-ray, they are going to appear at soap bubbles. Okay. What else? They're really aggressive and they can, spread locally, right? They're really aggressive. So these are the features which you have to remember. Okay, like we just mentioned again, first of all, we are covering the entire pathoma. In our bootcamp session, we are going to cover first aid. So if some points from the first aid are missing, we are going to, do that once we are just doing the first aid, and we're going to discuss these pathoma concepts as well. So I'll be asking you there the pathoma concepts from you guys, and if we have some extra points added into the first aid, we're going to do it there, right? So till now we are focusing on pathoma. The next cancer, which is really important and really high yield, you will be having it, in a lot of your MCQs, is Ewing sarcoma. Ewing sarcoma. So who is going to be telling me about Ewing sarcoma? As you guys have already did, you worked with Dr. Hasnain. Yes. So is it a malignant tumor or benign tumor? What do you guys think?
It's a
According
malignant.
to
Malignant tumor.
it's a sarcoma, right? It's going to be a malignant tumor of your bone. What else? What do you guys think? In which area of your bone most likely one is going to develop this Ewing sarcoma? In the epiphysis, metaphysis, or diaphysis? What do you guys think?
Diaphysis.
Perfect. So it's going to be a tumor present in diaphysis of your bone. Perfect. Right? And on X-ray, there is going to be a characteristic finding which is highly specific for Ewing sarcoma.
Onion skinning.
Onion skin.
Perfect. It would appear as onion
Onion skin appearance.
skin appearance. Where else do we discuss onion skin appearance?
Hypertrophy of vessel. Hyperplastic.
Okay, we have two types. Okay, two types of arteriolosclerosis.
One hyaline and
One is
hypertrophy.
hyaline, and the other one was
Hypertension.
hyaline and hyperplastic. Okay, hyperplastic arteriolosclerosis. And hyperplastic arteriolosclerosis, which is going to be, leading to the end organ failure as well. If it's exceeded a lot, you are going to be having onion skin appearance. That is basically hyperplasia of your smooth muscles occurring in a layering pattern. So if you just zoom it in the picture, you're going to be having onion skin appearance. Same is the case with Ewing sarcoma. If with X-ray, if you just look at the diaphysis of an individual having Ewing sarcoma, you'll be having bone laid down in a layering pattern, which would appear as an onion skin. Is it clear? On X-ray. Is it clear? Hello?
Yes.
And these malignant tumor occurring in Ewing sarcoma are going to be derivative of what thing? What do you guys think? They're going to be which cells in nature?
Neuroendocrine cells.
They're going to be neuroectoderm. Ectoderm in nature. Did you guys remember the neural ectoderm? 3 layers: ectoderm, mesoderm, endoderm. Your notochord, which is going to send signal, transforming into neural plate or neural ectoderm. Okay. Another thing, let's just revise. What is the remnant of this notochord in a normal individual, which we discussed 2 to 3 days back? Remnant
Nucleus.
of
Nucleus
that
pulposus.
is
Nucleus pulposus.
nucleus pulposus. Perfect. Sorry?
Continue. It's not time to watch the TV. It's not
not,
time yet.
sorry, I couldn't get you.
Sorry.
I think she's talking someone else.
Okay, okay, no problem. So it's going to be, onion skin appearance as we discussed. And the biopsy is going to give you round blue cells. Really, really important, right? So you're going to get round blue cells on biopsy. Where else did we find round blue cells, if you guys remember from the lectures of your lymphoma? Did you guys remember? A lot of blue cells. Okay, just find it and just tell me tomorrow, right? From your lymphoma
Round
lecture.
blue cells we find in the neuroblastoma, medulloblastoma, and
Mhm.
the small cell lung cancer.
Okay,
Yes.
perfect, right? So you're going to see it in neuroblastoma, small cell lung cancer. These round blue cells can be present, right? Okay, which type of mutation is going to be present or leading to Ewing sarcoma? That's also really important. Yes,
1122 translocation.
that's going to be 11
22
22.
translocation. So if you remember in lymphomas, we can also have a lot of round blue cells, right? We can have a lot of round blue cells, like the inflammatory cells can come there. On the histopathological sides, they can appear as a lot of blue cells, right? Lymphomas as well, and chronic osteomyelitis.
Ewing sarcoma.
Right? So how to differentiate whether it's a slide given to you that's due to, that's a lymphoma, or it's a chronic osteomyelitis, or either it's an Ewing sarcoma. So first of all, you should know the translocation as well. The lymphoma won't be having this 1122 translocation, while if you have this 1122 translocation, it's most probably that you are having Ewing sarcoma slide on your histopathological side. Is it clear? Okay, so it's often, it's a metastatic since it's a, sarcoma, but it's responsive to chemotherapy. It responds really good to your chemotherapy, right? So it was all about Ewing sarcoma. Let me just give you a brief overview again. Ewing sarcoma. It's a sarcoma, malignant tumor, right? It's going to respond well to your chemotherapy, first point. It's going to be having ectoderm cells appearing as round blue cells. How to differentiate it from other lymphomas? It's going to be having 1122 translocation. On X-ray, it's going to be onion skin appearance, which is multiple layer of bones coming over one another. It's going to give you this shape. Okay, so these were all about our bone tumors. Let's discuss tumors of our cartilage. So the rule again is same. If you have oma in the end, that's going to be your benign. If it's sarcoma in the end, that's going to be your malignant. Is it clear? Hello? And another,
Yes.
Yes.
all of the benign tumors of your cartilage are going to be present in the peripheral region of your body. For example, in the bones of your hands, or the cartilages of your hands, and in your feet. Is it clear? In the medullary portion, right? So it would arise in the medulla of your small bones. And another thing, it would be present in the small bones. Is it clear? But if it's a sarcoma, it's going to be present centrally, right? For example, where it's going to be present within the medulla again of your pelvis and central skeletal, right? Pelvis and central skeletal. Is it clear? So let me just write down our first tumor, that is chondroma. What do you guys think? Is it a benign tumor or a malignant tumor?
Benign.
If it's a benign tumor, we are going to see it in the medulla of the distal part of your, or the peripheral part of your body, or the central part of your body. Yes,
Peripheral. Peripheral small bone.
perfect. So peripheral portions of your bones, that is going to be, in the medulla of your small bones, where the hands and your feet. Okay, so it was all about your chondroma. Then you have chondrosarcoma. Is it a benign tumor or a malignant tumor?
Malignant.
Malignant.
Huh?
Malignant.
It's a malignant tumor. Perfect. Are we going to see this cancer of your cartilage in the peripheries or in the central area of your body?
Central area.
Perfect. So they're going to be present in the medulla of your pelvis and central skeleton. Is it clear? We also have some metastatic tumors. Like these were the primary tumors which your bones or cartilage have, right? So we have some metastatic tumor as well. Like from the other parts of your bodies, tumors can enter into the bone. You guys know that. What are they? Okay. So the most common primary tumor, okay, and usually they are going to be osteolytic in nature. What do we mean by osteolytic and what do we mean by osteoblastic? Yes. As we discussed, some of the
Osteolytic means punched out.
okay, lytic and blastic, right? So as we discussed that some of the tumors, whenever formed in the bone, they can be osteoblastic. That is, the bone is going to be growing. You are going to have a bony growth, right? That's a growth is your osteoblastic. Lytic is breaking down your bone, right? So do you guys know now the difference between lytic and blastic? Blast is formation of your bone. Some tumors can lead to outgrowth of the bone, that is extra bone growth. While osteolytic basically means that some tumors, metastatic tumor, if they metastasize to your bone, they can lead to osteolytic lesion. That is, they can eat down your bone, right? So we are going to be having punched out lesion, right? Which is going to be due to eating down your bone, right? So the classic tumor, if you guys remember, is your prostatic cancer, right? Which we're going to discuss in detail in our reproductive module. So prostatic carcinoma classically produce osteoblastic or osteolytic lesion. What do you guys think?
Osteoblastic.
Osteoblastic.
Osteoblastic lesion. Okay, that is the bone is going to grow. It's not going to be eating down your bone. So most of the metastatic tumors, bone tumors are going to be osteolytic in nature. If you guys remember, we discussed one tumors which is going to result in punched out lesion in your skull. What was that? Cancer of
Multiple myeloma.
that was multiple myeloma. Did you guys remember that?
Yes.
Okay, so let's discuss multiple myeloma in a little bit detail. It's going to be tumor of which cells? Yes, we discussed it in detail.
Plasma cell dysplasia.
Plasma cells. Plasma cells are responsible for making your antibodies, right?
Yes.
Yes.
Okay, so we are going to be having a lot of antibodies. It's going to lead to hypercalcemia, lytic lesion in your bones. If they it can lead. Can it lead to a myelodosis?
Yes. Yes.
If the light chain comes out in the urine, you are going to give it a respectable name. What was that?
Bence-Jones.
Bence-Jones protein, right? So we already discussed it in a big detail about multiple myeloma. So most of the tumor which metastasize to your bone are going to be osteolytic in nature, apart from prostatic carcinoma, which is going to be osteoblastic in region, right? So this was all about your bone tumors. Let's discuss joint. Okay, so what is joint? We know that joint is basically connection between two bones, right? So the joint itself have a lot of things. Like, for example, if this is your knee joint, right? So you have your femur here, your tibia, okay, your fibula, you have a joint capsule, you have a synovium, you have a articular cartilage, upon these bones. That's some of the component of your joint. So we have a synovium, which is going to release the synovial fluid in order to lubricate the joint, in order to avoid the extra friction. Is it clear? So joint is basically connection between two or more than two bones, right? Okay. So we discussed that bone is basically made up of which cartilage, type 1 or type 2?
Type 1.
Type 1. Problem with type 1 cartilage can lead to which pathology? We discussed osteogenesis
Affected.
big imperfecta, right? Not only the problems of bone are going to be seeing, but why do we have blue eyes? Blue cornea. That's blue cornea, right?
Yes.
Why?
Exposure of the choroid vein.
Okay, choroidal veins exposure, because we are going to be having, type 1 collagen is also responsible for making that thick sclera, right? Okay, so that's blue, not cornea, that's blue sclera, okay? What else? We can have some, problems with hearing as well, right? So, okay, so the cartilage is basically going to be, which collagen is going to be helping in production or making your cartilage?
Type 2.
Type 2. So that's BONE1 and cartilage, right? Not cartilage. Okay. So type 2 is going to be helping in strengthening, your joint capsule, because we have cartilageous structures here. It strengthen the joint. Okay. So we have synovial lining as we discussed, and this line basically secretes a fluid which have hyaluronic acid. And the reason for that synovial fluid full of hyaluronic acid is going to lubricate the joint in order to facilitate smooth movement, in order to avoid that maximum kind of friction there, right? So let's discuss our next topic, that is degenerative joint disease or osteoarthritis. Okay, really important, really high yield osteoarthritis. The only thing which you guys should just keep in mind regarding osteoarthritis is that it's going to be a wear and tear disease or problem of your joint, right? So how can we get maximum amount of wear and tear? We can get a lot of wear and tear if we are using a joint for a longer period of time. Am I right?
Yes.
Okay, so if you are just using joint, for a longer period of time, a time would come and we are just excessively using it for a longer period of time. So a time would come that, you can simply think, if I'm just using this joint, that the concentration of this lubricating material can decrease. If it just decreases, and if you are just overusing the joint, so what happens? These cartilaginous structures can also worn out, and in the end, the bone would be left, which would be just rubbing against the bones, right? So we can have this condition that's going to be osteoarthritis. So my question for you guys, that this pathology is going to be seen in elderly more or in young individual more, if it's due to wear and tear?
In elderly.
In elderly.
In elderly. Why? Because elderly, as compared to a young individual, have used their joints for a longer period of time. Okay, so it's going to be major risk factor for elderly, right? So the effect is going to be limited number of joints, not only a lot of joints are going to be involved, because that makes sense as well. Which joints normally do we use, right? So an individual, if using a joint and if still that joint have a lot of force upon it, right, or an area of weight bearing area joint, most probably are going to get this wear and tear. Why? If I have a lot of weight on this joint, so it's more obvious that we are going to be having a lot of friction there. And since we have a lot of friction in those joints, what would happen as a result of that? In order to get wear and tear for those joints are going to be really easy. Okay, so you can see that the limited number of joints, and which joints which are involved in your weight bearing things, like for example the hip joint. As you are walking, hip joint is going to carry your entire upper body weight, right? So it have a lot of weight. The lumbar spine, since it have to carry a lot of weight. Similarly, two joints which you have to remember, the distal interphalangeal and proximal interphalangeal joint of your fingers, really important. DIP and PIP. Okay, these joints can be involved, because whenever we are using our hand, so mostly these joints are going to be used more, right? DIP and PIP. Is it clear? Hello?
Yes.
Can I say that these wear and tear can be worsened with two things? If I have trauma to the joint, or an individual is obese. Can I say that? Because if
Yes.
an individual is obese, his joints are going to carry more weight as compared to an individual who is thin. And as a result of that, his joints, individual is, whenever he is obese, his joint is going to be having more wear and tear, right? So trauma and obesity can be, the risk factor of getting your osteoarthritis, much easier. Okay, so the classical presentation are going to be joint stiffness in the morning that worse during the activity. Okay, so it's really important, and it makes a lot of sense as well. Okay, since this problem is due to wear and tear or using your joints, so if an individual is resting his joint, so the pain is supposed to be decreased, because the problem is due to wear and tear. Am I right?
Yes.
So as
Yes,
he
sir.
wake up in the morning, his joints would feel relaxed because we are not using them. But as he continue to do some activities throughout the day, it's going to be worsen, right? So it's going to be really important point in your MCQs in order to pick which pathology is it. Because we'll be discussing rheumatoid arthritis after this, and the story there is opposite. Why? Because in the rheumatoid arthritis or any inflammatory condition, the pain is due to inflammatory cells, right? Pain is due to inflammatory cells. And in those cases, if an individual is resting, if he's sleeping, if he's giving rest to his, joints, so all of the inflammatory cells at that time can enter your joint, and as the individual wake up early in the morning, he'll be having a lot of inflammatory cells there in the joints. So he's going to be having a lot of pain there, right? But as an individual with inflammatory condition are using up his joints, so with using, what happens, these inflammatory cells can redistribute, they can enter back into the tissue. So using of the joints, if it's relieving the pain, it's your rheumatoid arthritis, any kind of inflammatory problem going on. Is it clear? Hello?
Yes, yes, sir.
So an individual with osteoarthritis, since it's due to wear and tear, so as he give rest to his joints, the pain is going to be improved. But if an individual with osteoarthritis is using his joint, the pain is going to be worsened. Is it clear?
Yes,
Hello?
it is.
Perfect. So in the question, Shem, if they're just telling you we have an individual, he wake up in the morning, the joints were really stiff, but as he just did his normal daily activities, the pain was, decreased, or it was less. So what do you guys think? Is it an osteoarthritis or rheumatoid arthritis? What do you guys think? Hello?
Rheumatoid.
Okay, perfect.
Rheumatoid.
Oh, so as we discussed that this is our joint, if we have a lot of wear and tears, what would happen as a result of that? If I'm just rubbing these joints against one another, so this is your articular cartilage. So some of the pieces of the articular cartilage can be broken down if I'm just using them again and again, micro pieces. Can that happen with wear and tear?
Yes.
Having a lot
Yes.
of weight, obviously, right? So whenever these pieces of cartilage enter into the joint space, what do we call those small pieces then? We call them joint mice. What are joint mice? These are small mice,
Mm.
how do we draw mice? Like that. Of cartilage entering into the joint. Basically, these aren't mice, okay? They are basically pieces of that cartilage which basically break off the articular cartilage during this wear and tear process, okay? So with a lot of friction, with a lot of wear and tear, ultimately a time would come that these cartilages are all going to be eaten up. Am I right? Hello?
Yes.
So now
Yes.
you'll be having bone rubbing against your bone. Am I right? Hello? We'll be having bone
Yes.
rubbing against the bone. And if bone are rubbing against the bone, what can happen as a result of that? We can have reactive bony outgrowth, right? So that are also to be called as osteophyte formation, right? So whenever the bones are rubbing against the bone is going to be having a reactive outgrowth then, right? And this reactive outgrowth are basically called as osteophyte formation. Osteophyte formation. Is it clear? So as we discussed, if the same kind of thing happen in two joints in your finger, what are they? DIP and PIP. Am I right?
PIP.
So
Yes.
that will result in the formation of these osteophytes, and with that, the joints are going to grow a lot, right? The joints are going to appear as a big nodes, right? So in this case, I'll be just showing you a picture. As a result of this reactive bony outgrowth, it would present as in the DIP and PIP as a big nodes present, which are called as Haberden nodes and Bouchard nodes, right? So if those nodes at the DIP are called as Haberden nodes, and those nodes which are due to reactive, osteophyte formation at the PIP are called as
Butchered.
Bouchard nodes, right? So this was all about your osteoarthritis. So let me just give you an overview, then we are going to move forward, right? Osteoarthritis, the only thing which you have to keep in mind, which is going to make this pathology really easy for you, is wear and tear using the joints. Along with that, what are the factors which would aggravate this wear and tear problem? Trauma, obesity.
Elderly. Obesity.
Yes. So as it is due to wear and tear, so it's going to be seen in which individual? An elderly individual, right? While rheumatoid arthritis is an autoimmune disease. So we discussed in our immunity lectures in detail. Autoimmune diseases are more common going to be seen in which group of individuals? Very specific.
Female.
Female.
Okay, that's childbearing female. Why? And what was the reason behind that? Because the estrogen do not let the reactive T cells to die. We can have a lot of autoimmunity. Estrogen is basically helping these autoimmune cells to survive. They're going to inhibit their death. Okay, so most of the autoimmune conditions are going to be seen in female woman, right? That is of childbearing age, having a lot of estrogen, right? So we discussed that we can have osteoarthritis. It's going to be, born these due to wear and tear, seen in elderly. Most probably those joints which are going to bear a lot of weight, like hip joint, lumbar spine, knees, and the hand. It's going to be DIP. That's going to be PIP, right? We discussed as an individual is resting, the problem is due to wear and tear. So with rest, the pain is going to be relieved, and with working, the pain is going to be worsened, which is opposite to your inflammatory processes. Because at rest, the inflammatory cells can enter, it can cause a lot of pain, but with movement, these inflammatory cells can be redistributed to the other tissues, which is going to decrease your pain. Okay. So we discussed DIP, we discussed PIP. Okay, if we have a big nodes due to osteophyte, okay, we just discussed joint mysis, we discussed osteophyte, reactive boning, outgrowth due to a lot of friction, bone against bone, right? Osteophyte formation. Okay, if we have nodes due to osteophyte formation at the DIP, what are they going to be called?
Abandon
And-
nodes.
And PIP, Bouchard nodes. Okay,
Bouchard nodes.
okay, perfect.
So, quick one, Dr. Ahmed, to clarify, the joint mince only occurs in the large joints. Is that correct? It does not occur in deep. In deep, it is the formation of the large nodes.
Yes, it's going to be mostly present in the in the large and the big joints. Okay,
Okay. I see. Thank you.
perfect. Then we have our rheumatoid arthritis, right? So we discussed rheumatoid arthritis is basically an systemic autoimmune disease. Autoimmune disease. Okay. So in this basically, okay, seen in which group of individuals as we discussed? Women of childbearing age. Okay, we know that. We discussed it's going to be associated with HLA-DR4, if you remember it from your immunology lectures, right? Okay, so these autoimmune things which I'm going to discuss that what are going to be present in this autoimmunity, right? So what are they going to do? For example, if this is your joints, your joint. Okay, let me just draw a joint again. We discussed that tibia, fibula, knee joint, for example. We have articular cartilage, and we have a layer called synovium, which basically make your hyaluronic acid important for lubricating the joint. Am I right?
Yes.
Hello.
Yes, you're right.
Basically, the inflammation is going to be, we are going to be seeing inflammation of synovium in your rheumatoid arthritis. Is it clear? So the inflammation is going to be seen in synovium, right? So it is going to be characterized by, involvement of joints, as we discussed. So we are going to be having inflammation of synovium called sinusitis. And as the synovium get inflamed, what are we going to see as a result of that? We are going to be having granulation tissue. Granulation tissue. Do you guys remember what is granulation tissue?
Formation of new.
Okay, for example, if we are just forming a new tissue, right? For example, if somewhere we have necrosis or we have trauma, if you have cut any part of your tissues as a result of, regrowth of that, first of all, we'll be having granulation tissue, So it's a disorganized tissue, having a lot of blood vessels and having some actin and actin fibers as well. Am I right? Hello?
Yes.
So you can just make the story in your
Inflammatory cells
mind.
around each other.
Sorry?
Inflammatory cells around each other. This is granuloma.
That's granuloma, right? Okay, so granulation tissue and granuloma, they are different things, right? So as we are just regenerating a tissue, it can be due to trauma, it can be due to necrosis, if your body is regenerating a tissue, so simply you can just make this story into your mind. We are going to discuss it in detail in our general pathology, right? But you should just keep one thing in mind: granulation tissue is going to be a weak tuft of tissue in order to replace that dead tissue, right? It's going to be having a lot of blood vessels, a disorganized kind of tissues. Along with that, it's also going to be having actin fibers, right? So actins are contractile fibers. Am I right? They're contract. Am I right? Hello?
Yes.
Yes.
It's basically inflamed tissue, right? Okay, so it's okay. We are also going to be having inflammatory cells as well, right? Because we are just regenerating a tissue. So actin basically contracts, right? So as a result of, you can just keep this story in the mind that as the synovium get inflamed, then we are going to be having granulation tissue, a lot of inflammatory process going on. So as this inflammatory tissue is formed, it's having a lot of actin fibers as well, right? Actin. So what these actin is going to do, these actin are going to contract. So if you have a lot of granulation tissue here, so the actin fibers are going to contract, right? Because their nature is that they contract. So if they contract, won't they make the joint space really narrow,
Yes, they will.
Yes.
right? Okay, and they would contract in different directions. Like some of the granulation can, contract this bone in this direction, the other bone in the other direction. So it would lead to swan neck deformities, right? Have you seen the swan neck deformity of you have a clear picture of that. The joints are going to, due to these contractile actin fibers, the joints are going to be moving in different directions. So you're going to be having really disorganized joints, right? Right? So in the fingers,
Yes.
appear as a swan neck. This is your swan neck, right? Like this. Okay, so this is basically due to granulation tissue having those actin fibers, which are basically pulling these joints away in different directions. So we can have a really disorganized joint in motor practice. Is that clear?
Yes.
Yes, it is.
As it is due to inflammation, inflammatory cells are also present there, right? So we are going to be having fusion of the joints. If they are just bringing them towards one another, so we'll be having fusion of joint, which is basically known as ankylosis, which we'll be discussing in our next topic. Okay. Okay. So we are going to be having morning stiffness that improve with activity. Am I right?
Yes.
Okay. We are going to be having. Why? Because with activity, these inflammatory cells are going to settle down. They are going to be redistributed to different tissues. Okay. And which joints in the hand are most probably going to be involved? That's going to be your
Metacarpophalangeal and proximal interphalangeals.
Okay. PIP
Yes.
and
Usually
And
metacarpo.
MP. Metacarp
Okay.
MCP.
Metacarpophalangeal MCP, right? And would we be having involvement of DIP?
No.
No. No involvement of DIP is seen. DIP is going to be seen in which pathology which we discussed?
Osteoarthritis.
So knowing this fact, you can correct a lot of MCQs on your world, right? If the DIP aren't involved, PIP and MCP involved, if you do not know, if you just forget the details of this pathology, so only looking towards the DIP involvement, you can exclude out rheumatoid arthritis, right? If DIP is involved. Is it clear? Hello? So if the PIP is involved, proximal interphalanges, we have that actin fibers, contracting them in different direction would lead to swan neck deformity, right? Okay. And if the wrist is involved, the wrist joint can be involved, the elbow joint can also be involved, the knee joint can also be involved, right? So whenever we have involvement of the wrist, it can deviate the wrist. Why? Again, due to that contractile actins, right? We can have involvement of, the elbow as well, right? So we can have somehow, deviated or, stiffened elbow as well, right? Okay, so since it's an autoimmune condition, so we are going to be having fever, myalgia, weight loss, and we are going to be having rheumatoid nodules. So what are rheumatoid nodules? Rheumatoid nodules can be seen in the skin, in the visceral organ, which are basically, which basically are going to be having central zone of necrosis surrounded by epithelioid histiocytes, right? Central necrosis with epithelioid histiocyte. We can have Baker's cyst as well. You know what is Baker's cyst. These inflammatory cells can inflame your pleura, leading to pleural effusion. lymph node, lymphadenopathy, and interstitial lung fibrosis. So what are going to be the lab findings which are really important? We are going to be having something called rheumatoid factor. What is your rheumatoid factor? So in this, basically, we are going to be having IgM autoantibody against
FC portion.
FC portion of IgG.
of your IgG, right? We're going to be having IgM against FC portion of IgG. If you have, if you just, insert a needle into the joint and just extract out, the synovial fluid, so it will be having a lot of inflammatory cells. Am I right?
Yes.
Hello? So a lot of
Yes.
cell that is neutrophils. So you're going to have abundance of neutrophils. Along with that, you're also going to be having high protein in the synovial fluid. And why is that so? You're going to be having high protein because inflammation basically increases your vascular permeability, right? So the vessels surrounding the joints are going to have a lot of proteins here, right? The complication of, okay, it's a chronic autoimmune disease, right? It's a chronic autoimmune disease. So you guys are going to be telling me from your hematology section we discuss, we can have an anemia which is associated with chronic diseases. What is that?
Anemia of the chronic disease.
Okay, we have anemia. We discussed it in detail of chronic disease. What do we have in anemia of chronic disease? Hepcidin. What hepcidin? Hepcidin basically sequester all of the iron in your macrophages of your liver, and as a result of that, we can have that iron deficiency, which is going to lead to which anemia?
Microcytic.
Normocytic,
Microcytic anemia. Yeah.
That's going to be normo or micro?
Normocytic.
normocytic.
Normocytic anemia.
It's normocytic.
Okay, it's going to be normocytic first, and then it's going to transition into microcytic. Is that there? Hello?
Yes.
Yes,
Okay.
yes.
Okay, perfect. The other group of pathology, okay, who is going to be giving me overview of this rheumatoid arthritis? It's really important. Then we are going to move forward. Yes, let me just pick someone for that. Okay, anyone want to volunteer? Any volunteers? Dr. Victoria, yes, please.
Okay, I can just try. All right. So you said for rheumatoid arthritis, it's commoner in females, it's an autoimmune disease, is an inflammation of chronic disease. So what happens is you have like a joint with the synovium. When you have an inflammation in the joint, you have a formation of granulation tissues. And over a period of time, there's accumulation of granulation tissues, which will cause actin, right? To cause contraction on that joint. And that contraction will cause narrowing of the joint. Right?
Yes.
Leading to leading to stiffness of the joint and other symptoms that manifest with narrowing of the joint.
Do we have involvement of DIP?
Yes. No. DIP is not involved in rheumatoid. You have PIP and then MCP.
Perfect.
the
With
joint involved.
activity, would the pain improve or worsen?
It improves with activity and then arthritis is worse.
Why?
So this is because during rest you have stiffness of the joints because of narrowing, but activity there it's kind of relieved, yeah.
Okay, that's great.
But yes, but during activity it is
Yes,
it's improved.
inflammatory cells are going to redistribute back into the tissue. Okay, so we have seronegative spondyloarthropathies, right? Seronegative spondyloarthropathies. So let's just break down this name. Seronegative. Sero means serum. Negative mean what's negative? We won't be having rheumatoid factor here.
Rheumatoid factor.
Serum is negative for rheumatoid factor in these pathologies, right?
So,
Okay.
sir, I have a question before we continue.
Yes, please.
Dr. Ahmed, I
Yes,
have a
please.
question before we continue. So you talked about rheumatoid factor. Is it always positive in rheumatoid arthritis?
Okay, sorry.
So you talked about rheumatoid factor, right?
Hmm.
Being one of those things you find in rheumatoid arthritis. Is it always positive in rheumatoid arthritis?
Yes, in rheumatoid arthritis is going to be positive, right? So we can have some other things as well there, which we are going to, read it from first aid. Anti-citrullinated antibodies, right? Okay, so we are discussing a next group of pathologies which are seronegative. What do you mean by seronegative? That we won't be having rheumatoid factors here, right? Okay, and spondylo. What does the word spondylo mean? Spondylo means spine, right? Hello.
Yes.
So it
Yes.
means that and arthropathies, pathologies of your joints. So the serum is going to be negative for rheumatoid factor, and we are going to be having pathologies of joints, with joints which are going to be present in your axial, that is spine or axial skeleton. Is it clear?
Yes.
So we have a group of pathologies. The first is ankylosing
Spondylo.
spondyloarthritis. Ankylosing. What do we mean by ankylosing?
Fusion of the joint.
Fusion of joint. Spondylo, axial, and spine. Arthritis, inflammation of your joints, right? So before discussing the details of ankylosing spondyloarthritis, let's just, based on the name, let's just discuss which features are we going to see, right? So for example, if this is your joints, like, your spine in the end, the coccyx part and everything. So if they just fuses with one another, right? If the joint fuses with one another, it's going to appear as a stick, right? You know,
Yeah.
having these
Yes.
only the lines present in the stick, right? Because the joints have been fused. So it's going to, can it, can the appearance be same as that of a bamboo stick?
Yes. Yeah.
Right? If
Next
the
it
joints
shows a
Yes.
are
bamboo spine.
fused, yes, so
Yes.
we are going to be having bamboo spine. Why? Because we
On
are having
X-ray.
ankylosis at the spine. On X-ray, it's going to appear as bamboo spine, right? So it's going to be arising in young adults, most oftenly male, not female, because we have that seronegative, seronegative, no rheumatoid arthritis. It means it's not an auto-inflammatory condition, right? So male are going to be more, having these seronegative, okay, male individual, because autoimmunity is mostly going to be seen in female, as we discussed, right? We can also have some extra articular manifestation as well. And what are going to be the extra articular apart from your joints? What can be affected? We can have uveitis and aortitis, right? So the uvea can be affected. What is uvea? Do you guys have any idea? Uvea? This is your eye. Yes. Anyone?
Can you repeat your question?
What is uvea?
UV is a
Um,
meaty layer of the eye.
It's a medial.
Yes.
Middle.
Middle vascular layer.
Okay, uvea is basically the medial vascular layer between the sclera and retina, right? So anterior uveitis is going to be, the anterior part of uvea, but we'll be discussing all of the structures in detail in our ophthalmology in our next module, that is your CNS, right? So we are going to be having some extra articular manifestation, that is uveitis and aortitis, right? What is aortitis? Inflammation of your aorta. If your
Mhm.
aorta is inflamed, can it lead to aortic regurgitation? If it becomes
Yes.
dilated,
Yes.
how? We discussed in our cardiovascular section, if you remember. If this is your aorta and we have inflammation here, it would lead to dilatation of your aorta. And as the aorta become dilated, so the aortic cusps are going to be moving farther away from one another. So if they move far away from one another, it means that we cannot close the valve. If the valve cannot be closed, so what happens? the blood can leak back into your heart. Is it clear? Hello?
Yes.
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 So this was ankylosing spondyloarthritis, which comes under the category of seronegative spondyloarthropathies. The next one is Reiter syndrome, and it's really simple to remember, right? You don't need to, you know the details of Reiter syndrome. You only have a single mnemonic in order to remember Reiter syndrome. And what is that? Can't, this individual can't see.
Can't
This
see.
individual can't,
Can't climb the tree and can't
Yeah,
pee.
can't
can't
see
see.
and can't
Can't climb.
climb the tree. So if this individual, why do he can't climb the tree? Because it's going to be inflammation of your joints, arthritis. Right? So we're going to be having arthritis. That's why individual with Reiter syndrome, which comes again under category of seronegative spondyloarthritis, right? You know the features are same, negative for rheumatoid axial skeletal involved, right? Okay. What else? Can't be urethritis, right? So it's going to be urethritis. If you guys remember urethritis, we discussed in detail in our renal section. Do you guys remember which bugs can cause urethritis?
Chlamydia, Trachomatis.
Trachomatis.
What
Gonorrhea.
else?
Is it gonorrhea? Gonorrhea. Okay, yeah.
Gonorrhea, right? So chlamydia and gonorrhea. So if an individual get Reiter syndrome right after, he can like get it right after chlamydia trachomatis infection as well, because the urethritis component is also really important, right? And can't see, right? Again, he can get conjunctivitis this time, right? Conjunctivitis. Okay, so what is conjunctiva? We are going to discuss it in detail in our ophthalmology session again. But for the Reiter syndrome, the only details which you have to keep in mind is seronegative spondyloarthropathies. Can't see, can't be, can't climb the tree. Associated with chlamydia trachomatis and weeks after GI infection. Okay, so the last one is psoriatic arthritis, right? Which comes again under the category or in the of your seronegative spondyloarthropathies, right? So you have psoriatic arthritis. What does the name suggest? We have arthritis, inflammation of the joints. We know that, but it's going to be seen in 10% of individual who get
Psoriasis.
Skin lesion. Sorry.
skin lesion. We are going to get it our dermatology section, okay? So it would involve the axial and peripheral joints both, right? Axial are going to be involved. The DIP joints of the hand and feet are most commonly affected. DIP are going to be affected. And as the DIP are affected, so for example, if this is your finger and DIP are affected, it's going to be just like that, okay? Okay, the fingers are going to be like that as the DIP are affected. And it would appear as a sausage, fingers, or toe, right? So we can have fingers or toes, with this psoriatic arthritis can affect, and it would just appear as a finger, just like a sausage, right? Is it clear? Hello?
Yes.
Yes.
Okay, perfect. So our time for today is finished. I'm really sorry. Nowadays, like I'm just working on something, and apart from that, like I'm just in my recovery phase. So really sorry for that. Okay, and soon I have an announcement for you guys. I'll just announce that in 1 to 2 days. So as you know that we have some problems related with the like um, links uploading on time, okay, and things. So basically I'm getting a proper application ready by our team, in which you're gonna get each and everything there, right? So I'm going to announce that in detail. We're going to be having a proper webinar. So I'm going to transition all of the students here from the WhatsApp into our LMS, okay? So our LMS is going to be prepared within a week, and all of the students are going to get links there in the live session. You have a proper you know sidebar for each and everything. Even the assessments are also going to be took there. The assessment scores are going to be uploaded there. So you'll be having your each and every student is going to be having his or her own ID, right? And everything. So I'm just working on that. So I'm going to soon announce that. Okay. Thank you so much. Hope so you guys enjoy and see you tomorrow.
Thank you, doctor.
Thank you.
Thank you.
Before you, my mom is